Hello, everyone, and welcome to another edition of For the Health of It. I'm Lou Beccaria, and thanks for tuning in. We're always happy to have you with us. Well, today we have the pleasure of talking with Dr. Jeffrey Rosenblum, and the topic is going to be men's health, and we're going to talk about the urological issues related to men's health. And I think you'll find what Dr. Rosenblum has to say to be very fascinating and very instructional as well. So, Dr. Rosenblum, welcome to the show.
Thank you. It's an honor to be here, and I really appreciate your graciousness and the hospitality of your staff as a whole.
Well, we're happy to make you feel at home.
Thank you. Thank you.
So let's kick this off by telling us a little bit about your own background.
Sure.
Doctor.
I'm originally from New York City, originally Brooklyn, New York, and I went to college and medical school at the 6-year accelerated medical program at Boston University. So I got accepted to medical school from high school, and it was an accelerated program. And the acceleration was achieved over the summers as far as that goes.
So that's like cramming 8 years into 6 years.
Pretty much. That's right. Then I matriculated at New York University for their residency in urology. And urology residency is 2 years of general surgery and 4 years of urologic surgery. So that included New York University Medical Center, Sloan Kettering Cancer Center, Bellevue, which is a level 1 trauma center, the VA, and a number of other outlying hospitals as well. And when I finished there, I was recruited by a group in the Chester County area. And I was with a group from 1994 to 1996 in Chester County. And then from 1996 to 2013, I was in solo private practice.
Okay.
Then a year ago, in 2013, we merged with the Phoenixville group, and many of the physicians I had known from being in the area for nearly 2 decades. So it worked out to be a very nice conglomerate, a very nice marriage, and both from a personal and professional perspective, I'm very happy with it.
Oh, that's great. We're glad that you're here in Phoenixville, and
Thank you.
glad that you feel at home.
Thank you, sir.
How did you, I asked this of all the doctors, what made you gravitate to this specialty?
Sure. I can tell you a very romantic story that I was a union plumber and then went into urology. Unfortunately, that's not the case. In medical school, 90%, as with anything else that you do, it's really the influences that you've had. So I had my mentor, my advisor, was a urologist. Very magnanimous fellow, a Dr. Robert Crane, and that's how I got interested in it. And for our viewers at home, urology is really the study, the surgical and medical treatment of male and female urologic disease, the urinary system, the genital system. So it's a nice mesh of various treatment options. We can treat patients in the office. We can treat patients in an operating room for more serious issues, but a very nice, versatile specialty.
Yeah. Since you mentioned that you address the issues of both men and women, what are some of the most common issues that you deal with men and the most common issues with women?
For men, it would have to be prostate, whether it's prostate enlargement or prostate cancer, which is very pervasive, vasectomy in men, erectile dysfunction in men as well. In women, we deal with incontinence, women that have had childbirth or that have had pelvic surgery. Sometimes that loosens up some of the ligaments that support some of the vital structures, so they can leak urine at times.
Okay.
And of course, a combination of men and women, kidney stones, cancers of the various urologic organs, bladder, kidney, ureter, etc.
Okay. What causes kidneys, by the way, since you've touched on that?
Sure. Kidney stones?
Kidney stones, yeah.
Sure. Most kidney stones are diet related. In other words, a kidney stone is when the salt in the urine comes together and forms these gravel-like particles. Well, that can happen for a number of reasons. Either they're taking in too much calcium or oxalate more commonly, or they're getting dehydrated. And that allows this state of supersaturation where these minerals precipitate out of the blood into the urine, and it clogs up the kidney and can cause a lot of pain, as you may have heard.
So that's another reason to drink a lot of water.
As long as you don't have any medical indication to limit the amount of water, yes, to keep the urine flowing, to produce at least 2 quarts of urine a day.
Now, what would be a medical indication to not drink a lot of water? Because you hear a lot about, water's the best thing for
Sure.
you. Just drink a lot of water.
Sure.
It's good for lots of things.
Well, we have to temper what we say. Someone who's very debilitated, who has heart problems, congestive heart failure, where the heart is not pumping, you don't want to overload them with fluid.
Oh.
But for younger patients, it really shouldn't be a problem.
Okay.
But we always check with the patient's medical doctor.
So if someone has a heart condition, why is too much water a problem?
Well, say that the heart is not pumping well, you're overloading the plumbing,
Oh,
overloading
the
the system
stress.
with fluid, yes, and you're stressing it too much, so that fluid's going to back up.
Okay.
And one of the areas where it backs up is the lungs, so they get this edema or swelling and congestive heart failure.
Okay.
The other issue with kidney stones is some of the main food products that cause it. Tea, iced tea is a big one.
Really?
Chocolate, and the dark sodas like Coke, Pepsi, because that has caramel coloring, and that turns into oxalate, and that forms calcium oxalate, and that's one of the most common types of stones.
You just ruined my day. There's three
Well-
of the top things I like.
Everything in moderation. Everything in moderation. Whether it's kidney stones or erectile dysfunction, it has to be in moderation.
With the stones, and then we'll kind of leave the topic, but
Sure.
Is it treatable by medication, or does it always have to be treated when you have gallstones surgically?
Kidney stones.
Kidney stones.
Some can be treated surgically, and some can be dissolved with medications. The stones that can be dissolved with medications are known as uric acid stones. Some people, you may have heard, have gout, where they have excess uric acid crystals.
Okay.
That, if you alkalinize or raise the pH of the urine, you can dissolve these stones. Now, on the flip side of the coin, calcium oxalate, that's a hard stone. That you really can't dissolve, so that has to be broken up. And we have many minimally invasive ways of doing that these days. There's shockwave lithotripsy, where we apply shock waves to the stone and crack it up outside of the body, so it's minimally invasive. For other stones that are caught in the tube that comes down from the kidney to the bladder, which is known as the ureter, we can treat that with that lithotripsy, shockwave lithotripsy, or we can do ureteroscopy, looking up with a little telescope and treating it with a laser.
That's fascinating. And all these different procedures that you've just mentioned, doctor, are they like new within the last 5-10 years, or they've been historically the kind of treatment?
They've been around a long time, for decades. The shockwave lithotripsy, which is the non-invasive way of treating kidney stones, has been around since about 1980. Actually, a company out of Germany, Dornier, started with the first lithotripsy. Some of the other options, as time progresses, are newer, are more novel. The ureteroscopy, there's always lasers that are being developed, but still, they've been around for decades as well.
My guest is Dr. Jeffrey Rosenblum, and we're talking about men's health, women's health, all the urological issues related to the human being, really. Let's kind of switch, doctor, and kind of go into the area of prostate health.
Sure.
Okay, with men. Tell us a little bit about that. You mentioned earlier, about a minute or two ago, that prostate disease can be pervasive.
That's
Okay?
correct.
And what do you mean by that? Does it mean it can be spread to the rest of the body, or?
I mean that it's very common in the population. And I think really, and I'm going to show this model if I may, the prostate, to start the discussion off, is a gland that sits below the bladder and wraps around the urethra. And its only function really initially is to provide motility and nutrition for the sperm, a fluid transport, if you will. Now, as the gentleman or man gets older, the prostate enlarges and it starts to squeeze the urethra where he urinates from. And it's like squeezing a garden hose. The flow starts decreasing. He starts getting up at night, making more frequent trips to the bathroom. So this is BPH, or benign prostate hyperplasia, or benign, meaning not cancer, enlargement of the prostate.
What causes, doctor, the prostate as you get older to enlarge? Is there something about the aging process that causes that?
It is, it's genetics, and it's a natural part of the aging process. And to put it in perspective for our viewers at home, 80% of men at the age of 80 or more start getting symptoms from the prostate. So it's a very pervasive issue. After age 50, the prostate starts enlarging, and if it's benign, that's the BPH we talked about. But independent of that, prostate cancer is also very common in men. In fact, it's the most common solid tumor in men, most common cancer in men. And really, 1 out of 6 men in their lifetime will get prostate cancer. Now, that doesn't mean it always has to be treated, but it depends on the patient demographics, the patient's clinical scenario, and what's going on.
You mean if someone has prostate cancer, you may not treat it?
That's right.
never heard of
Take, for example, someone who's debilitated, someone who's elderly, say in their 80s or so, or 90s, and the prostate cancer tends to be, let's say, a low grade. In other words, not an aggressive type.
Yeah.
The odds are the patient will die with the cancer rather than of the cancer. Now, the converse of that is, take a younger man who's, let's say, in their 40s, 50s, that has an aggressive cancer, most likely that patient will need to be treated.
Okay. So in an older person, like 80 and above, the treatment could be actually worse than the actual condition of the cancer.
That's correct, and there's been a number of studies about that. In fact, years ago, we used to screen for prostate cancer after age 50. And if someone was African American or had a history of prostate cancer in their family, we'd move that down to age 45. Then in 2009, some guidelines came out and said, hey, the American Urologic Association says people at age 40 should have a baseline rectal exam and also a PSA, which is prostate-specific antigen blood test. That's the chemical that the prostate that should be between a certain number for various individuals.
Yeah. And what are those numbers?
Usually it's 0 to 4. However, someone who's 40 to 49 years old should have a PSA of between 0 and 2.5. Someone between 50 and 59, between 0 and 3.5. And it goes up from there. However, if someone had a PSA blood test of 0.2, and then the next year it's 1, then the next year is 2, that's a high velocity.
Yeah.
So that patient would warrant a biopsy as well.
Okay. And exactly how is the biopsy done? And how is it a really invasive procedure? Does it take a long time?
It's a minimally invasive procedure, and there's 2 indications to have a biopsy. Number 1, something doesn't feel right on rectal exam. And when we do a prostate exam, here's the back of the prostate over here, we feel it with the index finger. So it should feel soft, smooth. Any hardness, any irregularity usually should be biopsied.
Okay.
Additionally, someone with an elevated PSA or prostate blood test that's elevated may need to have a biopsy. The biopsy is about a 15-minute procedure. We do it right in the office. And what we do is we anesthetize the area of the prostate. So the patient lies on their left side. We put numbing liquid in the rectum, and we take a small needle and we infiltrate or numb up the nerves around the prostate. Then we look with an ultrasound probe as we're doing that and take samples of the prostate. The patient is on antibiotics for this, so hopefully will not get an infection, but that certainly is a risk, and that's the way it's done. The patient really feels almost nothing the way we numb up the nerves around the prostate.
Okay. We're going to take a break for commercial right now, Doctor. Thank you very
Thank you,
much. We're talking with Dr. Jeffrey Rosenblum about the urological issues, both in men and women. We'll talk more after this word from our sponsor. Stay with us.
At Phoenixville Hospital, we understand that life is too short to spend hours in an ER waiting room. And we know that in an emergency, minutes really do matter. And so, our entire team is committed to working diligently to have you initially seen by a clinical professional in 30 minutes or less. Because at Phoenixville Hospital, we think you should spend less time waiting and more time getting better. The 30 minutes or less ER service pledge, right here at Phoenixville Hospital.
Hi, welcome back to For the Health of It. I'm Lou Beccaria. And for those of you who are just tuning in, we have the pleasure today of talking with Dr. Jeffrey Rosenblum, who is a urologist here at the Phoenixville Hospital. We left at the first half, we were talking about prostate issues. So before we leave that topic, I'd like to ask you, Doctor, what about diet? How does diet relate to all this?
Sure. Of course, a healthy diet is very good for prostate health as well. So a diet that's low in fat and high in soy-based products that they have in the Eastern countries, in the Asian countries, there's a very low incidence of prostate cancer as far as that goes. So that's number one. Number two, there's been studies about lycopene, which is an antioxidant. You find that in tomato-based products, in watermelon. That has been shown to have a protective effect on prostate cancer. Interestingly enough, people take many vitamins. You know, you hear all about these supplements these days.
Yeah.
And for many years, it was thought that vitamin E, selenium, those vitamins, those minerals, have a protective effect on prostate cancer. However, this is not the case. In fact, it's the vice versa. Those elements, vitamin E and selenium, actually have been shown to have a worse effect and to cause, or men that take these have a higher incidence of prostate cancer.
Yeah.
So that recently came out as well.
I'd just like to ask you if we could stop there for a second. In terms of medical research, you know, for years you said it was one way, now it's another. Why the 180-degree switch?
Well, there's a number of trials that come out, and the one that I was referring to was the SELECT trial, selenium and vitamin E. It's the acronym for that. And initially they thought it had a protective effect, but it didn't. So there's been many trials where actually it had been going, as you said, in one direction, and now it's a 180-degree switch. And this is the benefit of research and being involved in that. And here at Phoenixville Hospital, we actually have a study going on, and that's called the MEAL study, M-E-A-L. And that stands for Men's Eating and Active Lifestyle Study, showing that diet and exercise can actually have a protective effect on prostate cancer.
Wow.
So it's always a dynamic science, medicine in general and urology in particular.
Stick around and it'll change. Right?
Sure, the only constant is that there will be change.
There will be change,
yes.
Yeah. Sticking on this topic, what about meds? Can meds that are given for prostate issues affect a man's libido, for example?
That's right. It can affect the libido, and it can also affect the erections. Some of these that affect erections are the blood pressure medications are a big one. A lot of people have high blood pressure or hypertension. They're put on these diuretics or water pills, as they're known as. And that can cause erectile dysfunction or the inability to get the penis firm enough for intercourse. Beta blockers, to work on the heart as well, can cause this.
What if there is no erectile dysfunction in terms of, but there is no semen? Does it affect semen coming out?
Some of the prostate medications for enlarged prostate that actually loosen up the tone or the tightness of the prostate can cause that. You see, we have two classes of medications for prostate enlargement. One of them loosens it up, as I said. Those are called the alpha blockers. The other ones shrink the prostate down. The first ones, the alpha blockers, actually open up the prostate, so there's better flow of urine. However, in order to ejaculate or to release the semen, that goes backwards. So as a side effect, the man may not have a forceful or any ejaculate coming out. And it's of no clinical consequence unless they want to have more children. They just have to stop the medication.
I see. Okay. And lastly on this topic, before we switch to women's issues, race differences. Are there any race differences in the prevalence of prostate problems?
There are, especially prostate cancer. African Americans have a higher incidence of prostate cancer, and not only that, they have a more advanced, more aggressive form of prostate cancer. And that's been tallied up in various demographic studies. So again, that's a risk factor.
Is there research going on to figure out why?
Well, that goes into genetics, and we have research going on at multiple tertiary care institutions, and they're trying to figure that out.
Yeah. Okay. Now let's turn our attention, doctor, to women. What are some of the issues with women's urological problems, and what can be done about it?
Sure. By far, one of the biggest problems with urologic issues in women is incontinence, which is the leakage of urine. This can occur after childbirth. This can occur after pelvic surgeries. Some women have had the uterus removed or hysterectomy. And what that does is it loosens some of the ligaments that support the urethra. That's the tube that carries out the urine. And we have various ways of fixing this. It could be exercises. It could be medication, depending on the type of leakage that they have. And finally, it could also be surgery. And the main theme has been minimally invasive procedures, we do a minimally invasive procedure, which is called a sling, where we take a little material and we put it underneath the urethra, underneath the bladder, to prevent the urethra from swinging forward. And it's like a hammock to keep that up to prevent the incontinence. And taking what we talked about a step further, another issue we see in women is sexual dysfunction. For many years, we had been treating only half the problem, the men's erectile dysfunction. But 50% of it was also women. And these were more erudite topics, but they included desire problems, arousal problems, orgasm problems, and pelvic pain syndromes. So that was really another issue that we treat. Additionally, we also treat urinary tract infections in women. Women, as we talked about the urethra, have a shorter urethral length. The tube that carries out the urine is shorter in women than it is in men. So that can allow bacteria to go backwards and cause infections in a number of cases.
The hormonal changes that take place during midlife for women, is that what is a precipitating cause for these kinds of things you've just mentioned?
It certainly could be a confounding factor. Younger women have more estrogen, which makes the mucosa, or the lining of the vagina, the lining of the urethra, thicker. As menopause and as the woman gets older, that decreases in size and there's less tissue turgor, there's less water pressure, there's less coaptation or squeezing of the urethra. So that certainly can cause that as well.
Yeah. Okay, let's talk about vasectomy. Going
Yes.
Going back to the men. This is a procedure that's been going on for quite a long time.
That's right.
And I understand from our previous discussion that there's been lots of advancement in
Sure.
the way this is done over the last 30 or 40 years.
Yes.
So could you tell us about that?
Sure. Well, vasectomy, for our viewers at home, is basically male sterilization. When the man doesn't want to have any more children, we remove a portion of the vas deferens. The vas deferens are the tubes that come from behind the testicle and carry the sperm out to the ejaculatory ducts in the prostate. So on this image here, and also our friends at the Phoenix Media Group can put this up on the Chiron as well, we have the testicle, the epididymis, and then the vas deferens. What we do is we remove a portion of the tube on each side to cause the sterilization. Now, traditionally, vasectomy was done with a scalpel, making an incision, removing a portion of both tubes, clipping them, tying them, and putting some stitches in. What I now do, is called a no needle, no scalpel vasectomy. And basically, we don't use a needle anymore initially for the anesthetic. We use a jet spray. So it feels like a little snap of a rubber band in the skin of the scrotum, the skin of the sac in the man. And then we don't use a scalpel. We make a little puncture with a specially designed clamp, remove a portion of the tube just like we did traditionally, and then close it up. And what this does is it's less tissue trauma. There's a quicker patient recovery and less discomfort in most cases.
Wow. How long has that procedure been around, Doctor?
Well, the no scalpel vasectomy has been around since the 1970s. It was brought over from China, where there was a population explosion.
I see.
The no needle is a little more recent than that. The no needle was used in podiatry. It's basically using a vaccine-type gun to put a high-pressure anesthetic through the skin without much tissue trauma and getting it into a certain underlying area. So we've modified that to use it in vasectomy. And it's great. It's a quicker recovery, and patients that are needle phobic, it works very well for them as well.
Yeah. With vasectomies, with any of these procedures, is it reversible?
The answer is yes, it is reversible, and we do reverse them. But we always tell the patient ahead of time, you should consider it an irreversible procedure. Just because we can cut out the scar tissue and approximate or sew the front end to the back end of those tubes doesn't mean that there'll be a pregnancy afterwards.
Okay.
And extrapolating that a step further, if there is no sperm and no pregnancy afterwards, we can actually do something else. And I do a lot of these. We go into the epididymis with a small needle. That's that gland in back of the testicle, and we evacuate sperm, and then we work with our colleagues in reproductive endocrinology, the gynecologists, to put that into the female partner to achieve fertilization.
Okay. With women, when the women have a procedure done where they won't have any more kids, is that irreversible?
You know, it can be reversed, but I'd have to have the gynecologist deal with that because that's their expertise. What I can tell you is the vasectomy in a man is much less invasive because we're going right under the skin with those vas than it is doing it in a woman, tying the tubes, because that's an intra-abdominal, in the belly operation with general anesthesia. In the man, you just feel that vas right under the skin and the procedure is almost done.
Now, when a man has a vasectomy done, are there any side effects to it? Is there any scar tissue problems? Are there any scar tissue problems?
There can be, but it's a low likelihood. But anytime you cut the skin or a structure, there is a possibility of scar tissue. So the risks are low, but they include bleeding, infection, scarring, or several years after the vasectomy, the two ends can find each other, which can make the man fertile in some cases again. So we always check semen samples afterwards. But even though we check it, there's a very minute possibility somewhere down the line it may reverse itself.
Yeah. My guest is Dr. Jeffrey Rosenblum, and we're talking about all the urological problems, both men and women. Infertility in men. Tell us a little bit about that. What causes that?
50% of male infertility is usually caused by a varicocele. And those are dilated veins that sit next to the testicle in that diagram that you just saw. And that can heat up the testicle and actually kill sperm. So 50% of infertility is on the man's side, and a varicocele we see very pervasive. Additionally, there's various genetic issues that occur, some chromosome abnormalities, some gene abnormalities that can cause male infertility. And certainly lifestyle, smoking, marijuana usage, alcohol usage has been shown to decrease sperm in men. So it really goes full gamut.
Is this a hereditary issue with men?
In some cases, it can be a hereditary issue. For example, some men harbor the cystic fibrosis gene. These men have absence of the vas, or those tubes, those spaghetti-like tubes that we talk about. That's a congenital genetic issue.
Okay. We have just about 30 seconds left, Doctor. So any final words that you'd like to mention?
I have to say it's been a pleasure to be here. Really, urology involves all facets of men and women's health. If you have any other questions, anything that we didn't discuss on the show, please contact me. The phone number is 610-933-1133, or on the Chiron 877-MD urine. That's a toll-free call. Additionally, we have a couple of websites, vasectomyonthego.com and Rosenblum, Rosenblum, urology.com. And it's been an honor to be here, and thank you for really making this more of a global effort. If we can get the word out there to help men, to help women with all their urologic issues, we appreciate that. And certainly the catalyst of this has been yourself, Mr. Beccaria, as well as Mike, Sean, and Ben here at Phoenix Media Group. We want to thank everybody for tuning in, and I really appreciate the time.
And thank you for taking time out of your practice, Doctor, to be with us.
It's my honor.
It was fascinating. Very
Thank
well.
you. Thank you.
And thank you for tuning in. It's been our pleasure to bring you this very interesting and important show on urological issues in both men and women. I'd like to thank our TV team who put the show on the air for us today. Our show was directed by Sean Hensey, and we received technical assistance from Ben Warner. We received also production and producing help from Mike Miller, as well as Laurie Cunningham and Carolyn Park. Our sponsors, as always, have been the Phoenixville Community Health Foundation, the Phoenixville Hospital, the Phoenixville Healthcare Access Foundation, and the Activate Phoenixville Area Community Wellness Program. I'm Lou Beccaria. It's really been a pleasure to be with you folks. And remember, if you're healthy, you're wealthy. I'll see you next time.